Vamos a hacernos en el centro, porque es que hay muchas sillas, ¿no?
Vale, vale. ¿Dónde me siento?
Tú eres la reina.
Exacto.
Tú te sientas donde tú quieras. Yo me siento aquí al lado tuyo.
Dale, listo.
Espérate a ver. ¿Qué? Okay. Take a seat. Sit there. You sit there.
I sit here?
Yes, yes.
Okay, you tell me what to do.
The queen and the king. Okay. Bueno, vamos a dar inicio a los casos desafiantes asociados a cirugía de glaucoma. Llegó la hora con más acción el día de hoy. Entonces, antes de que se nos vaya a dormir JJ, que ya tiene pinta de sueño. ¿Y dónde está Cosme? Ya se fue a dormir. Vamos a empezar con Mix Complication, complicaciones en Mix. Nos va a hablar JJ. Dale JJ, welcome.
Aló. Bueno, primero que nada, las gracias porque esta es mi última. ¿Se escucha? Mi última presentación, así que gracias por estar acá a esta hora. Vamos a hablar sobre complicaciones de mix. ¿Reconocen qué es lo que está puesto ahí en la diapositiva? Ese es un bypass, a mitad de camino. No tengo conflicto de interés con la presentación nuevamente. Y yo creo que lo más importante en la cirugía mínimamente invasiva y en toda la cirugía realmente es reconocer qué es una complicación y qué es lo que uno tiene que esperar en el periodo postoperatorio. Por ejemplo, la trabeculectomía, si ustedes leen el paper original de Kearns, él dice en el texto que cuando se desarrolla una ampolla es consecuencia de un fallo en la técnica. Esa es la definición original de Kearns. Y como saben, después eso cambió la definición y se definió como que formaba ampolla y a través de eso disminuir la presión. Pero inicialmente, en la descripción inicial de la técnica por él mismo, el desarrollo de una ampolla era considerado una falla. ¿Qué pasa con la pérdida de células endoteliales? O como le puse aquí yo, la muerte prematura de un dispositivo que era súper bueno. Ese es el bypass, que era un dispositivo que iba al espacio supracoroideo y que funcionaba muy bien. Yo todavía tengo pacientes, tengo por lo menos 4 pacientes puestos antes que los retiraran, que están controlando presiones con un dígito, cosa que es bastante buena para cualquier cirugía de glaucoma. Ya no lo tenemos más. ¿Y eso por qué es? Estrictamente no es por una complicación, es por una falla en la indicación de técnica, es por una falla en la recomendación que daba la empresa de cómo hacer la cirugía. ¿Y por qué es eso? Si ustedes se fijan acá, los pacientes que no tenían anillos visibles del bypass de cámara anterior tenían una pérdida endotelial que era absolutamente comparable con los controles. En cambio, los pacientes que tenían 3 anillos visibles tenían una pérdida endotelial de un 10%. Y eso hizo que se retirara el dispositivo del mercado, porque la empresa no puede asumir que ellos daban la instrucción de ponerlo mal. Entonces, eso no es una complicación del procedimiento, no es una complicación del device, sino que es una indicación de mala técnica. Todos los procedimientos de glaucoma conllevan una pérdida endotelial. Todas las cirugías intraoculares conllevan una pérdida endotelial. Los devices que van al canal de Schlemm tienen pérdidas de células endoteliales que son significativas desde el punto de vista estadístico, pero no son significativas desde el punto de vista clínico. O sea, el paciente, si le baja el recuento endotelial de 2.250 a 2.150, que sería un N suficiente, va a dar estadísticamente significativo, desde el punto de vista clínico no pasa nada, es lo mismo. De la misma forma, los desprendimientos coroídos después de la cirugía, de glaucoma en general y aquí especialmente en el caso del GAT, llegan al 50% en la primera semana de desprendimientos coroideos. Y eso desaparece rápidamente durante el primer mes. La única diferencia que tienen los pacientes es la presión intraocular en la primera semana, que luego se iguala. No hay diferencias significativas en la presión, como tampoco en el número de medicamentos y en las complicaciones postoperatorias. Y acá, el uso de medicamentos. Que el paciente tenga que usar medicamentos tampoco es una falla del procedimiento. Todavía yo creo incluso, pero antes era más, cuando uno les explicaba que los pacientes no iban a dejar de usar medicamentos y probablemente vienen a bajar de tener que usar 4 a tener que usar 1, se acuñó el término MEX. No sé si se acuerda el doctor Ike del término MEX, Minimally Effective Glaucoma Surgery. Pero eso es porque le estamos pidiendo algo que no es. Estamos comparando la cirugía mínimamente invasiva, los dispositivos angulares, con la trabeculectomía, y sabemos que no es así. ¿El ifema es una complicación de la cirugía angular? No es una complicación de la cirugía angular. Como vemos aquí, este es un glaucoma infantil. Estoy cerrando las heridas por ese motivo, digamos. Vean cómo aparece el reflujo sanguíneo en la zona donde están los colectores que quedaron destechados después de hacer el GAT. Más o menos entre el ifema que se presenta en los pacientes es debido a esto. Y esto se repite en todos los procedimientos. Cuando uno hace un CAJUC es lo mismo, se ve el reflujo en la zona de tratamiento y eso es absolutamente esperable. Para que los dispositivos que están apuntando al canal de Schlemm funcionen, el paciente tiene que tener un sistema de drenaje que esté de alguna forma todavía saludable, de otra forma no va a funcionar. Y el reflujo sanguíneo que tenemos en el momento de la cirugía nos está indicando que el paciente está bien y que la indicación que hicimos es correcta. Esta es la imagen que uno tiene habitualmente de la cirugía. Este es un paciente con un glaucoma juvenil con presión de 30 con terapia máxima. Al día siguiente, como ven ahí, presión 17, usando un medicamento. Y después de 2 años, el paciente está con presión de 10, usando un medicamento y manteniendo la visión. Típicamente, como mostraba Hugo en la mañana, uno de repente se encuentra con estos pacientes que cuando llegan al control del tercer día no ven nada, pero a la semana eso ya se empieza a limpiar y a las 2 semanas la visión está normal y la presión empieza a controlar. Por lo tanto, lo que tenemos que hacer ahí es mantener la calma. Pero para poder mantener la calma, como decía Tiziana, tenemos que dedicarle tiempo de sí a estos pacientes. Ahí tenemos que invertir las papas, digamos. Hay que explicar cuidadosamente qué es lo que se espera que pase con la cirugía y por qué es bueno que esto pase, para así evitar la sorpresa del paciente y la angustia que implica llegar después de una cirugía que se suponía que era para ver y para bajarle la presión, sin ver y con la presión alta. Generalmente los dispositivos, digamos, que apuntan al Schlemm, apuntan a la eficacia, perdón, a la seguridad y el espacio subconjuntival a la eficacia, y los MIGS del canal están asociados con eventos adversos transitorios, como son el ifema y como son los spikes de presión alta. Y los del espacio subconjuntival tienen las complicaciones que se observan en la cirugía de desarrollo de ampolla normal. Este es un trabajo súper interesante que que publicó el doctor Azura Blanco, en que si bien todos los papers acerca de los distintos devices se esfuerzan en hacer una descripción de las complicaciones, necesitamos un instrumento que valide la severidad y una estandarización de las complicaciones para que todas las herramientas que disponemos hoy día sean comparables entre ellas. Por eso, como les comentaba en la mañana, el sistema de clasificación del ifema, por ejemplo, que propone el doctor Tanito, es tan interesante porque uno puede usar ese sistema para clasificar todos los ifemas en todos los distintos tipos de cirugía como una forma de unificar. Y como vamos a estar expuestos, y ya de cierta forma también, a la nube con el ingreso de todos los pacientes, eso nos va a permitir a la inteligencia artificial de alguna manera determinar algunos parámetros, algunos patrones de comportamiento que nosotros no lo logramos hacer, debido a nuestra inteligencia natural limitada. Pero se pueden tener complicaciones graves como cualquier otra cirugía de glaucoma. Por eso los cirujanos de glaucoma somos tan resilientes y tenemos una personalidad tan fuerte y tan resistente a los eventos negativos. Por ejemplo, esta paciente es una paciente de 46 años alta miope que estaba con terapia máxima usando 4 drogas, que tenía una enfermedad de glándulas de Meibomian y una enfermedad de superficie ocular importante, con intolerancia a sus lentes de contacto, lo que era un problema para ella porque usa un -12 en ambos ojos. Tenía presión 17, pero con unas córneas muy delgadas de 4,99 y 504, una excavación casi total en el ojo derecho y bastante razonable en el ojo izquierdo. Y en la conioscopía tenía un ángulo abierto, por tanto le hice un GAT en el ojo derecho que funcionó perfecto. El ojo derecho es el ojo malo, con excavación 0,95. Y después de un par de meses le hicimos la GAT en el ojo bueno. Al día siguiente de la cirugía tenía presión de 14, en ningún momento se quejó de dolor, ninguna molestia y tenía presión de 14. Cuando la examiné la semana, tenía una pupila fija en semimidriasis y un ángulo que estaba sellado y con extensas áreas de sinequia. O sea, me había hecho una red sabalía en algún momento. En el ojo bueno, paciente de 46 años, veía 20/20 con corrección. Y tuvimos que hacerle una cirugía para solucionar el cierre angular, solucionar las molestias que tenía producto de la pupila dilatada fija, y como Dios acompaña al ignorante, logré durante el proceso de hacer la gonosinequiolisis sacar la zona de adherencia entre el iris y el canal de Schlemm, con lo que en el postoperatorio ustedes ven que el canal está abierto. Luego me tuve que dedicar a reparar la pupila, como se ve ahí, dejándola más o menos en 3 milímetros, con lo cual nos asegurábamos también que no iba a tener dificultades asociadas con la fotofobia. Al día siguiente de la FACO estaba con presión de 14, con presión 20/20, con una pupila bastante razonable. En la última visita, que la vi en febrero, que son 4 años postoperatorios, con presión de 13 y 14, usando una combinación de prostaglandina en la mañana, sin fotofobia y con visión 20/20 espontánea en su ojo izquierdo. Hasta ahí todo bien, ¿no es cierto? Pero yo con la cirugía y con el hecho de haber tenido red sabalía, que probablemente fue porque le dejé una burbuja de aire muy grande, revisando después el video, le causé una pérdida de la acomodación y un incremento en el riesgo de esta paciente de desprendimiento de retina, porque le va a durar por lo menos 10 años más. Entonces uno tiene que ser estricto con las cosas que hace. Por supuesto, todos podemos cometer errores y tener complicaciones, pero es importante, como les decía, distinguir y diferenciar qué son las complicaciones de qué son las cosas que uno espera en el postoperatorio y advertirle eso al paciente para lograr tener una mejor relación y un mejor conocimiento de él. Shit always happens, pero siempre tenemos que seguir para adelante. Gracias.
Gustavo nos va a presentar EMIGAT AB interno como alternativa a trabeculotomía. Ok, Gustavo nos va a presentar EMIGAT AB interno como alternativa a trabeculotomía AB externo fallida, un caso clínico.
Bueno, sí, esto es un caso clínico bien interesante que quería mostrarles, y tal cual como su título lo dice, es una paciente que se le realizó EMIGAT posterior a una trabeculotomía AB externo fallida. Y les cuento un poco del caso. Esto es una chica de 15 años que ya tenía glaucoma congénito primario en ambos ojos. La primera vez que la veo yo es en octubre de 2019 y ella tenía antecedente de trabeculectomía y trabeculotomía al año de edad. Le había ido muy bien. En ese momento estaba con medicamentos solo en el ojo derecho, con brimonidina, timolol, y realmente las presiones venían bien. La primera vez que la veo, 20/20, fíjense cómo se ven ambos ojos, los ángulos. Si nos fijamos en la parte superior tenía sinequias, pero bueno, el resto del ángulo se veía bien. El nervio óptico, buen brillo, las paquimetrías relativamente normales, y ya los exámenes de campo visual, el campo visual está limpio en ambos ojos, y la tomografía de capa de fibras nerviosas, la OCT de capa de fibras nerviosas también está normal. ¿Qué sucede con ella? Digamos, luego de esos primeros controles, ya en 2020 me llega de nuevo la paciente y se eleva la presión del ojo derecho, ya estaba en 34, el ojo izquierdo estaba un poquito al límite en 22. Recordemos que estaba con 2 medicamentos en el ojo derecho nada más. En ese momento yo le formulo ya, digamos, escalo el tratamiento a 3 medicamentos en el derecho y 1 en el izquierdo, pero llegó la pandemia. Entonces no la vuelvo a ver sino ya hasta junio de ese año, y la presión seguía alta. Entonces empiezo como a escalonar un poquito el tratamiento y no veo resultado, ¿no? Entonces definitivamente algo había que hacer porque ya la presión de forma consistente estaba elevada. Esta es la microscopía especular de la paciente. Ella tenía un recuento de 1400 células, y en ese momento, digamos que de las opciones que al menos me hubiese gustado tener y no tenía en ese momento, quizás hubiese sido un láser micropulsado, digamos algo no tan invasivo, teniendo en cuenta que tenía un recuento endotelial bajo. Lo que tenía realmente en mis manos era un tubo, y en este caso era válvula de Ahmed, pero me planteé la posibilidad de, ¿será que podemos hacer un GAT del remanente de ángulo que todavía ella tiene? O sea, me pareció curioso, digamos, tratando de respetar lo máximo posible el endotelio. Y bueno, ya todos hemos visto, se ha hablado mucho sobre la técnica de GAT, pero cuando hablamos de GAT en glaucomas del desarrollo, en glaucomas congénitos, infantiles, juveniles, realmente es que la respuesta es muy potente, y de ahí a que me lo había planteado. Digamos que ya yo tenía en ese momento como un año y medio haciendo GAT, había tenido casos de glaucomas infantiles y me había ido muy bien. Entonces por eso fue que realmente lo pensé, y la literatura obviamente daba el aval. Entonces, ¿cuál era mi estructura mental o plan de cirugía? Mi idea con el ojo derecho era hacer una incisión superotemporal. Fíjense que por este lado había como una especie como de ciclodiálisis, no sé, o sea, estaba como muy abierto ahí. Entonces mi idea era hacer una goniotomía en el cuadrante inferonasal, irme de inferonasal a superotemporal y abarcar aproximadamente unos 150, 180 grados, y ya luego que metiera la sutura, hiciera ese recorrido, me metía por una incisión superonasal, retomaba la sutura y hacía una trabeculotomía del remanente de ángulo. Y efectivamente así fue. La evolución de la paciente inicialmente, en este momento yo siempre quitaba las gotas, solo les dejaba pilo. Entonces con pilo, presión de 16, a la semana me hizo un pico de presión, fui escalando con el tratamiento, y ya con máxima terapia la presión estaba ahí como al límite, entonces me mantenía ahí expectante. Entonces fíjense aquí vemos la zona, o sea, lo que vemos en las flechas rojas a la mano derecha es la zona de tratamiento que yo quería, y del lado derecho vamos a ver el video. Obviamente como está invertido, fíjense que yo voy rotando con el goniolente y se va viendo la trabeculotomía tal cual de toda la zona que le quería hacer el tratamiento. Entonces realmente la respuesta fue favorable. Obviamente seguía con medicamentos, pero me había ahorrado un tubo. Pero el problema no acababa ahí. Realmente el problema seguía, porque el otro ojo empezó a pedir también, porque la presión se le disparó. A medida que yo le iba controlando el ojo derecho, el ojo izquierdo empezó a descontrolarse. Y bueno, ya teniendo en cuenta que iba evolucionando el ojo derecho, yo dije, bueno, nada, vamos a hacerle lo mismo al ojito izquierdo. y en este sí pude grabar el video. Entonces fíjense, este es el cuadrante nasal. Yo hago ahí una goniotomía nasal. En este caso intento abordar el ángulo, pero realmente los glaucomas congénitos son bien complejos a veces de llegarle al ángulo, o sea, llegar al SLEM. Me fui a temporal y ahí sí logré entrarle al canal. Entonces, desde temporal me metí con la sutura, iba avanzando, avanzando, y ya luego lo que hice fue que me volteé al cuadrante nasal desde temporal y retomé la sutura e hice la trabeculotomía. Fíjense ahí cómo se ve, y le hice más o menos como 180 grados. Y en este caso ella sí hizo el pico el primer día, pero ya después la puse con máxima terapia y más o menos las presiones eran limítrofes, ¿no? Pero fíjense, ella 4 años y medio después de operada está manejando con máxima terapia, obviamente, presiones de 16 y 15. Entonces lo que digo es, la paciente está feliz, yo estoy feliz, me ahorré un tubo, me ahorré el deterioro del endotelio, obviamente. Sí, vuelvo y repito, está con máxima terapia, pero no tengo un tubo dentro del ojo. Y fíjense que el campo visual, tanto en ojo derecho como en ojo izquierdo, sigue estando completamente limpio, pues. Entonces, en este caso, que cuando yo me planteo algo así en un paciente, por ejemplo, de este tipo, es, si bien mi plan A era el GAT, también tengo que tener un plan B. ¿Y por qué lo digo? Porque es que el ángulo del glaucoma congénito es bien difícil lograr encontrar el SLEM. Entonces puede que yo tenga la idea de lograrlo, y me ha pasado, he tenido un segundo caso en donde intenté abordar el SLEM y simplemente no lo logré. Entonces, ¿qué pasa? Que si no tienes un plan B, te toca cerrar el ojo y dejar así, esperar y en otro momento hacer otro procedimiento. Entonces, mi recomendación es, sí es viable, pero tengamos un plan B, sea un tubo, sea láser, lo que sea, pero que nuestro plan A sea el GAT, pero siempre tener a la mano otra herramienta, porque no sabes si vas a lograr ese plan A que tienes en mente, ¿no? Pero bueno, a modo de conclusión, es un método bastante seguro, efectivo. Ya tenemos casi 5 años de esta paciente con éxito quirúrgico. Lo que les comentaba, tener un plan B por si, y bueno, obviamente el tema del ahorro económico, que creo que ya lo hemos abordado bastante. Muchas gracias.
Muchísimas gracias, Gustavo. JJ, ¿tienes algo importante que comentar?
Sí,
Te veo ansioso.
después se me va a olvidar cuando me quede dormido. Eso que dice Gustavo es tal cual, así como lo dice él. Así es. Cuando hay un paciente que tiene un glaucoma congénito múltiple operado, yo me acuerdo hace un año atrás operé un paciente de los 2 ojos de otra clínica que tenía 2 tubos en cada ojo, más una goniotomía inicial. Y le logré hacer GAT en los segmentos que quedaban todavía, y el paciente está controlando aún, después de un año. O sea, siempre hay que darle la oportunidad a la cirugía angular. Las cirugías angulares antiguas, no es por hablar mal de nadie, pero no eran tan regladas, y de repente las zonas que se pensaba que estaban tratadas, no estaban tratadas, y la cantidad de grados que están descritos en los protocolos como tratados, generalmente no son los tratados, son muchos menos. Así que ese es el consejo, escuchen todo lo que dijo él y grábenlo con mucha atención, porque es así.
Gustavo, debes sentirte bien, porque para que JJ le diga a uno algo así, eso mejor dicho, está convencido. ¿Sí o no? Ashraf, go ahead.
To thanks Luis Scaf for the invitation, and Lyle for his recommendation to me that to be part of this. And when he asked me to suggest topics, I suggest topics that related to cataract. And sometimes many things can miss from us, and also I'm involved in teaching education in many countries, in Egypt, my fellows, and also in some countries. So we can miss narrow angle glaucoma, and I'm going to highlight some points. So let's see. So I have no financial disclosure, but these are my disclosures to companies that I'm a consultant and a speaker to them. Let's think. Primary angle closure disease is often regarded as one single disease, entity in a clinical management and research, which lead to different combination of mechanisms in individual eyes. And these mechanisms include relative pupillary block, plateau iris configuration, lens-related mechanisms, and also possibility increased choroidal pressure. So these are some points it can be missed during our examinations. I'm going to highlight. So pupillary block, plateau iris, and iris-induced angle closure, ocular biometrics, and the lens-induced angle closure. So let's see. There are three categories. There is a primary angle closure suspect, there is a primary angle closure, and there is a primary angle closure glaucoma. And according to the pupillary block, the plateau iris, the lens position, and the lens thickness, we can categorize them. So this is very important. When you examine your patient with slit lamp, everything should be examined, including the angle, even if you are not a glaucoma specialist. This is very important in the report of before the surgery. So this, you should categorize your patient which category you are. So let's start. Pupillary block. I will highlight the most important. Don't read too much. It's the most frequent cause of angle closure. It's embedded the level of the eye, of the lens iris, definitely. And phakic eyes, and the lens plays a critical role for pupillary block. Without a lens, there is no pupillary block. And as less volt, there is less pupillary block. High lens volt, much pupillary block. The iris thickness, we are not all people have the same iris thickness. So according to the iris thickness. And the small anterior chamber dimension. So these are factors that can lead to pupillary block. We could miss it easily if we didn't meticulously examine the patient. So if it's like this, case of angle closure glaucoma, how to manage this? So let's see the video. I put the steps. I treated this patient in steps. She came to me, 45 millimeter mercury, full treatment, uncontrolled. Mannitol, whatever you are going, no problem. And the anterior chamber depth is 1.2, I think. It's very shallow. So most of the people are going to go, they're going to say, we are going to do phacotrap, and we are decreasing the size of the anterior chamber. For me, I don't agree. If you feel that the cornea is suffering, so it's not logic that you do a very nice glaucoma, very nice phaco, and you lose the cornea. This is failure. So first, save the cornea. You are not going to save the cornea unless you control the intraocular pressure. So this is what I decided. I decided to do a trabeculectomy with a full measurement I'm going to have. Trabeculectomy in these cases is not an easy because it's already shallow anterior chamber. So the main important that you control the filtration, titrated in a very small way till you have a good filtration and the anterior chamber start to deep. And this is what happened. You are going to follow the history of the video, are going to follow how we did it. So trap, and I used the mitomycin, and I used the mitomycin concentration according to three factors. The thickness of the conjunctiva, the state of the tenon, the long term of anti-glaucoma medication. I titrate the concentration I'm going to use. Not all glaucoma surgeons use the same concentration of mitomycin. This is very important. Because sometimes you can, with a high concentration, very thin conjunctiva, you can lose the blip. Very important in this, don't open the anterior chamber unless you evacuate the eye and inject the mycol. And then, very important, once you remove your trap, you are going to find that the iris is coming. This is the wrong iris to be peripheral iridectomy. Wrong iris. Never be tempted to cut it. milk it, push it again, and take the iris as much posterior as you can. This is the peripheral iridectomy, because you cannot see the peripheral iridectomy. If you see the peripheral iridectomy from the cornea, this is not the proper peripheral iridectomy. Close, mitomycin, I put a HeLa flow, everything is fine. I close the conjunctiva, as I told in the last, this is an art to close the conjunctiva as an art in the glaucoma. So this is how it looks. It was 1.5 anterior chamber depths, ended by 2.1 millimeter. This is okay, and the cornea start to be okay, and the PLEP is forming. 6 months after, the cornea start to be clear, tension is perfect, but the anterior chamber is still 2.1 millimeter millimeter. So to do phaco in these cases, you have 3 steps. First, the rexus should be a very nice size. Don't go out too much with the phaco probe. Do hydrodissection, not hydrodelineation, not hydrodissection. This is important. And always look for the PLEP. So this is a very shallow, just 2.1 millimeter. And it's not a soft nucleus. It's grade 2 to 3. So shopping, as everyone knows, shopping, and I never go with the phaco probe. If you go with the phaco probe, it will be very hard. You are going to lose the anterior chamber. So finish, just the nucleus, leave the rest of the lens, and always look for the CDE. Look for the CDE. Very important in these corneas, you don't need to exceed the CDE, because as much low phaco time and power, as much you are going to save the cornea. So in spite of this, it ended by 7.9, which is acceptable in these cases. And now it is just a cortex, remove, and you succeed to do a very nice, because you do the steps. You finish the glaucoma, you save the eye from the tension, the optic nerve, and then you deal with the cataract after cleaning of the cornea and become good. Everything is fine. Rexus, inject, and it's good. And mandatory in these cases, you remove the visco behind the IOL. So the other tissue that we can miss, the iris plateau. Iris plateau and iris-induced angle closure, you should diagnose. So it's an opposed of the trabecular meshwork, the anterior cleavage abnormalities, iris insertion in the scleral spore, it's abnormalities. So this is a case came to me. It was a 45, and the IOP is fluctuating to 28 with some medication stop. When I did a UBM, you can see the angles, and you can see the plateau of the iris in the right and left eyes. I did a simple cataract extraction for this patient, and I repeat the UBM after 3 months. You can see, look for the angle before, and the depth of the anterior chamber, and look after 3 months, the angle changed, becoming wide, and the depth of the anterior chamber become, and now the patient is stable, no rise of the IOP again, and no medication. So this is very important. What about ocular biometrics? Age, sex, family history, genetics. I will go rapidly. Just if age, take care, it is the age of 40. This is not take care about glaucoma. In sex, 2 to 4 times, it's more common in females. In family and genetic history, the first degree relatives affected, and the refractive error, high props are affected in these cases. Lens-induced angle closure, we have 4. Phacomorphic, ectopia lentis, spherophakia, aphakia. I will just discuss 2 of them, which are very important. The phacomorphic glaucoma is very important and has a pathway. You have a pupillary block, intumescence, and posterior pushing, narrowing the angle, anterior chamber ACD become less, more narrow the angle by increasing the pupillary block, forward movement of the lens. This is the mechanism. So how to deal? This is a very, very shallow anterior chamber, intumescent cataract. So in these cases, very important. I love to stain under air. And I learned that you close the paracentesis with a high viscoelastic, so you keep the air inside. Small, just staining. I wash the stain, and in these cases, never go Argentina flag is very easy. I go with the cystotome, go inside, aspirate. You can see the fluid is coming, 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 coming. You ballot the nucleus, Then spiral rhexis is very nice in this case. You start by 2, 3, 4, 5 to reach the best. It's like an onion, spiral, 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 spiral. Take your time as much as you can to be big, as much you are going to be easy during shopping and removal. I do all my cases vertical shopping. I don't use horizontal shopping. And this is a very hard cataract. In a long-standing intraocular pressure is high. So protecting the cornea, because these cases usually the corneal endothelium is not good. So look for the CDE. Always look for the CDE during working. Don't leave it. This is very important. You should, in these cases, does not exceed too much. 10, 12, 15, as much as you can, not more than this. As much as you can do shopping, in these cases, low CDE ratio will be. Don't forget viscodispersive. Viscodispersive. The endothelium is more expensive than the viscoelastic. Viscoelastic is cheaper than the cornea. So always remember this in your mind. Finish, finish, finish. You're going to end around 11, 12 CDE. In a very hard cataract, it's much acceptable. Ectopia lentis, the spherical, Luis Escaf. This is for you, for the question. It's displacement of the crystal lens. It's a spherophakia from the iris. It causes a pupillary block, shallowing the anterior chamber, giving myopia for the patient. It's a fake myopia. It is not the actual. And it leads to the AC become less. Different diseases can cause this, and the most common acquired zonial insufficiency. In these cases, it is meticulous to do what I'm going to do now. You see the spherophakia by the UBM, very clear. It's a spherophakia. It's very deep. The lens is very thick. It's spherical. So this is causing IOP rise. So the best in these cases, it's a very elastic anterior chamber. Femto rhexis in these cases is saving. As you are going to see now, I did the just the rhexis. Nothing else. I did the femto, the size, it's okay. Then you can see how the lens will be elastic in these cases. Even the rhexis, you remove it very difficultly. As you remove, all the lens is moving. It is not subluxated. It is an elastic zonules. It's totally different in the pathology. So I deliver it out. I don't work inside the bag. It's an easy, tack, tack. I take it from inside to outside because the core is the most hard. I finish it. This is not edited video, and then take care of the zonules. You can see during the IE, all the capsule are moving. You are going to see the zonules coming to you when I change my hand. See, I'm trying to get the whole bag, and the zonules are coming. It is not subluxated. It is an elastic zonules. Again, injecting to maintain the pressure. You can see now how when I'm taking see the whole bag and the zonules are coming. The whole bag is coming and back again. Why back again? Because the rhexis is still central. Means central that it's an elastic, not subluxated. Always look for the size and the center of the centration of the rhexis. So this is the cases, and this is how it looks post-operatively. I will end by 2 diagrams. I really love it, and I put it in my clinic. This is a 30-60 degrees opposition of the angle closure. This is the scheme how you can manage your glaucoma surgery if it's an opposition angle, and if it is a synechial angle, this is how you can think to treat cataract with glaucoma. This is very good. So my take-home message, angle closure glaucoma disease is a common cause of glaucoma and also pupillary block. Gonioscopy is the most important treatment of peripheral anterior of angle closure. Disease is tailored from different patient to another. I stayed 48 hours in Colombia, and this is my memories. This is half of my memories. I did a huge amount. I went to SCAF to the clinic. I worked at surgeries. I assisted. I enjoyed fun day and night. Really, thanks a lot. You made really my visit to Colombia is very good. And I'm going to meet you all in Nebraska soon. It will be the third time to Latin America. Thank you so much.
Ahora sigue live con todo por el trauma facopresiflo, cerclaje pupilo, lente intraocular fijado a esclera, Chariot.
Gracias, Claudia. ¿Ya está saliendo? Ok. Bueno, este es un casito de un muchacho de 29 años que se enfrentó a la policía. Le pegaron un bolillazo y pues ahí tiene para que, como dicen acá, para que sea serio. Entonces, el muchacho llegó a San Andrés, siempre nos demoramos en realizar el procedimiento quirúrgico, porque era un paciente de nueva EPS. Estoy tratando de mover esto y no me deja. Para que pueda, ok, ahora sí, listo. Y pues acá yo quería mostrarle a ustedes varias cositas. Lo primero es que decidí implantar un pressure flow en este paciente para el control de la presión. Tenía presiones en 40 y algo a pesar de 3 medicamentos. Y aquí hay varias cositas nuevas. Una de ellas es, vamos a hacer una fijación del lente intraocular con la técnica de Gabor-Chariot, es una fijación a esclera. Entonces a mí me gusta marcar tanto a 2 milímetros del limbo como 2 milímetros de longitud para dejar las ápticas dentro del túnel. Yo pienso que esas ápticas siempre deben ir tunelizadas. Y acá con un microcrescent hacemos unas preincisiones que van a 50% más o menos de espesor escleral para estar seguros que las ápticas están ahí, y con esta aguja número 27 hacemos nuestro túnel por donde van a pasar. En estos casos, pues siempre que hay que hacer un abordaje de vitrectomía anterior pero vía pars plana, entonces ven ustedes cómo después de posicionar ahí los trócares hacemos la vitrectomía tanto posterior, pues anterior pero vía posterior y vía anterior, y utilizamos el mantenedor de cámara. Entonces hacemos la capsulorrexis después de haber hecho la cinequiolisis en este caso, y si ustedes se dan cuenta, miren acá, tiene una gran diálisis que es algo más de 180 grados. Entonces yo sé que aunque acá tenemos a Ike, y que Ike siempre dice que hay que conservar, you have to leave the bag no matter what happened, right, Ike? Yo sí, en este caso, como programamos al paciente para implante de lente, hago la capsulectomía, limpiamos muy bien el segmento posterior y ahorita vamos a fijar el lente intraocular. Entonces, con nuestra aguja número 27, llegamos hasta el extremo distal, sabiendo que estamos dentro del túnel y con un recorrido de 2 milímetros. Eso le va a dar gran estabilidad al lente intraocular, va a generar menos tilt, y entramos de esta manera con nuestra aguja a 2 milímetros. Importante siempre liberar el áptica, que ella vaya sueltica, para poder posicionarla dentro de la aguja en una maniobra que es básicamente esta, y retirarla a través, retirarla con la aguja hacia la esclera. La técnica inicial está descrita con pinzas, y acá algo interesante es utilizar estos protectores de los ganchitos retractores, porque muchas veces se nos tiende a luxar el lente cuando empezamos a manipular el lado contrario, el áptica contraria. Entonces ahí lo fijamos, ya podemos retirar la otra áptica, cauterizamos, y acá, a diferencia del botón que siempre nos han dicho que se hace cuando se hace Yaman, yo achato y aplano el áptica de tal manera que ella quede metida dentro del túnel escleral. Entonces ahí vemos que terminamos el procedimiento quirúrgico, el lente se ve bastante centrado, y ahorita vamos a corregir la atonía pupilar o la midriasis postraumática. Entonces hacemos una pupiloplastia mecánica inicial, y lo otro nuevo de esto es utilizar la aguja 30 gauge de odontología que tiene 21 milímetros, en donde básicamente pasamos el polipropileno dentro de la luz de la aguja y luego lo vamos a suturar en los 360 grados. Nosotros que acá en Sudamérica hay veces es difícil conseguir la aguja CIF4 para realizar este tipo de suturas, esta es una excelente alternativa. Entonces, acá entre más mordiscos cojamos de ese borde pupilar, pues más simétrica y más redondita me va a quedar la pupila. Entonces, nos ayudamos aquí con una cánula 27, la retiramos y acá, sin salir de la cámara anterior, retomamos un poco antes de donde empezamos a suturar este cuadrante y volvemos a hacer lo mismo en los 360 grados, suturando y retirando la aguja a través de la paracentesis que es esta. En estos casos utilizamos 3 paracentesis y ahora acá pues se preguntarán qué hacemos si ya la sutura está por fuera. Pues volvemos nuevamente a canalizar nuestra aguja. Esto es como las abuelitas nos enseñaban a tejer y a coser. Y volvemos a entrar por la paracentesis donde dejamos cualquiera de los dos cabos, puede ser, pasamos nuestros puntos, salimos a través de la paracentesis y finalmente anudamos. Por lo general, la pupila va a quedar un poco más grande de lo que la dejamos en el primer intraquirúrgicamente. Siempre tener en cuenta que no quede demasiado pequeña para que los retinólogos puedan evaluar la retina en estos casos de trauma. Y finalmente, acá ubicamos nuestro pressure flow, confirmamos que haya filtración y cerramos en 2 planos. Y este es el aspecto posoperatorio al final del procedimiento quirúrgico con un muy buen resultado visual y además adecuado control de la presión intraocular. Muchas gracias.
Bueno, ahora vamos a presentar un video de Dan Linfield, que es un oftalmólogo del Reino Unido, que se excusa por no venir, está muy disappointed de no poder estar aquí, pero quiso mandar un video y vamos a presentarlos, no es tan largo y después vamos con Ike.
Hi everyone, it's Dan Linfield here from the UK. I'm hugely sorry I can't be with you in person. Hi everyone, it's Dan Linfield here from the UK. I'm hugely sorry I can't be with you in person, but I really hope I can come next year. I was asked to talk about plumbing the deep, or the treatment of cyclodialysis clefts. Thankfully, these are very rare. In Guildford, we have a strange population that's quite affluent, and most of our cyclodialysis clefts are caused by a squash ball injury or small high velocity ball injury, or by the cork of a champagne bottle. Whereas in other parts of the world, ocular trauma, assaults are much more likely to cause cyclodialysis clefts. So we still see them in Guildford, but the mechanism is very different to it is in other parts of the world. How do they present? Usually just this hazy red mess early on. So when you first get your ocular trauma, be it from a champagne cork or from a fist in a street fight, you tend to get a significant hyphema. And then you're not sure whether the angle damage is going to give you a high pressure, such as recession, or some lens damage, or a cyclodialysis cleft. It's kind of like a mystic, let's wait and see what we get. But we're going to talk specifically today about cyclodialysis clefts. The schematics of a cleft look really nice and neat. It's a very definite separation of the ciliary body from the scleral spur. It looks lovely and easy to spot, but in real life, they're quite hard to diagnose, at least with direct view. There's always some lovely images in textbooks showing this perfect cleft, But in reality, it's really hard to get such an image. And if you think you can see one, good luck, because often the IOP is 0 or 1 or 2. The anterior chamber is collapsed or soft. As soon as you put the lens on, A, it's tender and uncomfortable, and B, you just lose your view. The cornea just crinkles, you get striae, and you lose your observation. So these lovely images are often taken with viscoelastic support or with a recent fill-up of the anterior chamber at the slit lamp. You tend to have to rely on clinical features. So the obvious thing here is low pressure, serious hypotony. So pressures, 0, 1, 2, 3, 4. We're not talking about 10s, 11s, 12s. When you get a cleft, you really get a cleft. So usually it's a shallow anterior chamber, choroidal folds, hypotony maculopathy, choroidal detachments, etc. What can you do about it? What are the options? Well, obviously observe where possible. So often a small cleft, if left long enough, nature will do her thing and she'll close it down. So sometimes you get lucky. You atropinize to try and get some apposition and you want a bit of inflammation. So whereas for a normal injury, you'd give some steroid. If you got a cleft, you'd consider it stopping it because it would help put the pressure up and you might get it to stick down shut. You can use argon laser. So if there is a cleft there and it's small, you can use argon laser to help close it at the slit lamp. But that also involves you getting the gonio lens on to apply the laser, which is not very easy. You can go transcorneal, like digital SLT now does for SLT, but it's not so effective. Cryotherapy has been mentioned and used to be used 20 or 30 years ago, but it's pretty gruesome and horrible. It gives a really horrible burn on the conjunctiva. And often these patients are young, phakic, they want to look good, so sticking a horrible cryotherapy burn on the conj is not the best idea. So usually if you've got a cleft, we're looking at surgery. So we're now going to get into the gory surgical videos, which we all enjoy. The first video is courtesy of Keith Barton, who this is obviously one of his early videos. He's now changed technique, but he's brave enough to put this on the internet. And this is one of Keith's early videos. And this is really brave stuff. So he's made a conj dissection of full thickness scleral flap, and we're looking deep down here through into choroid, looking at all the lovely arteries and nerves. And seeing that cleft form, but we've got here vitreous coming out at us, and we've exposed a large portion of raw choroid. And there's a lot of manipulation here trying to close that cleft. So the risk of a hemorrhage is actually very low, but this does feel brave, and having spoken to Keith a few months ago about this, he doesn't do this anymore, but it's a good video to illustrate the technique of an open closure of that cleft. My biggest fear here is infection, vitreous loss, detachments, etc., and hemorrhage. We really are poking down that superciliary space here. Obviously, it's easy to see the closure because you can directly see it close with your bare eyes, but there's going to be quite a lot of globe disruption here in astigmatism. It's nice to know this exists, but I think we can all agree it's moved on since this technique. At the end, a decent closure is achieved. And obviously the scleral flap is stitched back down again, the conj is closed, and off you go. But I'd argue that eye has now got a full thickness injury to it, and its risk of future problems is significant. This is the semi-open technique, whereby I've already made the first flap, and then we're going to make a tiny little incision down to the level of ciliary body, and directly close it again. So the beauty here is we're not fully opening up, we're not getting all that significant choroidal exposure, we're not getting the hemorrhage risk, but we're still having to enter the eye, we've still got the risk of hemorrhage, but this is a much more refined technique, so I like this one. This is quite exciting, so thanks to Michelle Lim for allowing this to be used, but this is the ab interna approach, whereby you pass your sutures across the anterior chamber to directly close the cleft under gonio guidance. Now, you might need viscoelastic support here, often will, or an anterior chamber maintainer, but you can quite nicely see that cleft there, and you can, using some very skillful surgery, pick it up with a needle and lift it up. Now, this is made easier in this case by two factors. I think Michelle illustrates this technique beautifully. but this is fiddly surgery. This is a very long needle to pass through. And the two things in the favour of doing ab interno here is this is a cleft that sits nasally, so it's easier to sit temporally and pass a needle across towards the nose. And this patient is pseudophakic, so they've got a deep anterior chamber and a lens that you might touch by accident, and it doesn't really matter too much. But you can imagine trying to bring this needle out if this was under the lid, or if it was around the other way, temporal cleft, it'd be much harder. But you imagine trying to get this long, straight needle out when the heel of the needle might tap the lens at any point, like now. If this was a young phakic patient, I'd be pretty worried. So this technique, I think, it's lovely. It's got its purpose and its role, but I think it's probably best suited to the pseudophakic patients, and probably clefts that are mainly nasal or easy to access without tight lids. Difficulty being here is that most of our patients with clefts are often younger, especially if they're in the sort of street fighting trauma category. This is my technique that we've termed non-penetrating cleft repair. I think this is probably the sweet spot between the open, the closed, and the ab interno. But biggest tip here is using triamcinolone. So if you watch me now inject triamcinolone into the anterior chamber, you can really clearly see how it's flowing out to the side. It literally highlights that cleft to you beautifully. So if you can see it on gonio, it's easy. But if you can't see it, you use the triamcinolone flow to mark exactly where you want that to be. And then you may need some viscoelastic or an AC maintainer to see it with a gonio lens, but you know where to look. And I use the gonio here with viscoelastic support to mark the extent. So you'll be putting a purple pen on and marking and indenting to say that's how big the cleft is. It's then just a trab flap. So all of us glaucoma surgeons are happy to do a conjunctival porotomy, a good dissection. We don't need to worry about posterior flow here. We just get it open enough, bit of diathermy, and a traction suture to help access. Don't always have to do this, but it makes it easier. So I use a 550 micron guarded depth blade, so I know exactly how deep that scleral flap's going to be. So I use that flap to cut one cut, and then enter that cut with a crescent blade to just dissect along at that depth. And I know I've got a sort of 50% thickness scleral flap. I know how big I need to make it because I've already marked it. I'm then going to measure 2 millimeters back from the limbus and use my purple marker just to, again, give me some dots. And I'm then going to start blindly passing my suture to grab the ciliary body. So I'm going to be delving down, trying to pick up ciliary body and bring it up towards me and tie it off. Now, this is a bit brave. We're always thinking about don't penetrate, and you want to. So everything in your brain is saying, that's deep enough, but you have to go deeper. So I put these in thinking, I fixed it, here we go. Put the gonio lens on to check, and half of them didn't even bite. I barely got through sclera despite having a flap at partial thickness. So I had to go back and go deeper, deliberately trying to really pick up ciliary body and bring it up. And then you start to see the closure. Okay, so you can confirm with gonioscopy that you've completely closed the cleft. You see it's pretty neat. It's maybe not totally closed, but it's pretty much closed. And then you stitch your flap down and close your conjunctiva. And this was a young patient, a phakic patient, hence why I didn't want to do ab interno. I've put some triamcinolone in again just to check, and you can see now the triamcinolone is not flowing out the hole. We've closed it. The biggest tip here is what to do afterwards. These patients go from a pressure of 0 to a pressure of 40 or 50 the next day. So even though everything in your body is saying, I've got the pressure up, wow, let's leave them be, I don't want a low pressure again, you've got to give them full dose Diamox, timolol, dorzolamide, etc. to help get the pressure down. So next day, if you've closed it properly, the pressure will be sky high. The rest of the meshwork is completely shut down and hasn't worked for weeks, and suddenly it takes a while to wake up. So you have to give them Diamox support, otherwise you're in big trouble the next day. In summary, this is a rare but serious course of visual impairment. The open technique needs cojones grandes to help close it, and I'd say that's not acceptable anymore. Ab interno looks promising, but I think although the videos make it look elegant and slick, it depends on the location of the cleft and the lens situation of the patient. So I think this non-penetrating technique seems to be superior. And then think about triamcinolone to visualize the flow. And if you remember nothing else from today, it's if you do this and you close it up, Although you feel good on the table, you must give Diamox and you must expect a very high pressure the next day. Thank you so much for your attention, and sorry again I can't be there. Have a great meeting. See you next year.
Ok, vamos a seguir con Ike. Ike nos va a deleitar con una gran presentación que vi en Madrid y básicamente va a cubrir el tema de How do I manage positive vitreous pressure during my cataract surgery? And then after that, you will finish to close this session.
Okay, great. Everybody still awake? We'll be quick. We'll be quick. Okay, I'm going to show 2 cases, okay? And I'd like to see how the panel would manage these. Okay, is that fair? One of them you know, one of them you don't know, okay? So this is the case I'm going to show, if I can get the video here to play. This case, you're doing the surgery, everything's going great. You're the best surgeon in the world, the cataract's done. The IOL goes in, and you'll see that there is extreme positive pressure. This patient is a small eye. Ashraf talked about these small eyes. And coming out, you can see that there's iris coming out of the incision. The patient is getting uncomfortable.
Who is trembling, Ike? You or the patient?
No, the patient's moving. This is not me. This is my fellow operating. I don't know which one it was. It's an old video. But look at all the iris come out. The lens is coming out of the bag into the anterior chamber. So everything is shaking. Maybe the surgeon's shaking too. So the question is, what's going on? What would you do? How would you manage this case?
Okay, you said that is a small eye, probably.
Yeah, 21 millimeter eye. The case went no problem during the surgery. At the end, lens goes in, but the positive pressure came up.
Okay, in these cases, well, you have 2 options. We already start the surgery. Probably I will do a dry vitrectomy to deepen the chamber. Probably I will do it if you believe there is vitreous pressure. Because if you use mannitol in these cases, I believe it doesn't help. And the other thing that you can do, and I believe they do it in China, is to do a punction and drain a little bit of liquid from the back part of the eye. I don't know.
If it's my case, it's like misdirection syndrome, and the iris is coming out. So I will make sure that the speculum is not so tight, because this is a small eye, and sometimes the speculum, if the patient is in topical, in the last cases he's becoming to feel a lot, more squeezing can cause this, okay? So I will wait, just massage to decrease. Bobby Usher has a very nice way to make the eye hypotenuse in these cases. He do massage limbus. If it's not filled, I will wait. I can cover the eye, make the patient wait a little, put mannitol and see the patient again.
Okay. One?
It's the end of the surgery, the IOL is inside the eye, you are just waiting to wash a little and close. That's the situation?
Yeah, right now,
yeah. I put a couple of the stitches and wait.
But you put the stitches in the iris?
No, in the cornea.
But the iris is outside the incision.
No, you can, because in that time you can see what is happening inside of the eye. You can have blood. If you are going to do an entry for pars plana, you can have more hemorrhage. You don't know in that point. At least you can take a look inside of the eye and do a fundoscopy or whatever.
But how do you get the iris back in the eye?
The problem with that is the IOL is inside the eye. If you try to do a vitrectomy through the iris now, you can break everything. You can break.
I understand. He wants to do vitrectomy. No. Lai wants to do vitrectomy. Asher said no vitrectomy. You're saying just suture.
I think I wait, and when the pressure is a little down, I do the vitrectomy.
Wait, for how long you wait?
A couple of hours.
Couple of hours? Like this?
Yeah.
Okay. You're sitting on the table? Okay.
I want to examine the posterior segment. I want to examine the posterior segment to make sure that there is no effusion. This is very important in this case.
The patient is under mannitol.
How do you examine the posterior segment? How do you examine the posterior segment?
we examine the retina. It's during the FISON and with the
So you need to have indirect ophthalmoscope in the operating room.
Yeah.
How many have indirect ophthalmoscope in the operating room? I like the idea, but how many have indirect ophthalmoscopy in your OR? You have? Some do? Okay. I like this idea, by the way. I think it's important to know what's going on first. Right? Any other comments?
I'll try to somehow reposition the iris, close the cornea, and cry and call my retina colleague immediately.
Well, I mean, really, they were trying to get the iris back inside the eye. There was a extreme positive pressure. I mean, this lens is sitting up almost on the cornea. And even viscoelastic putting in makes the iris worse because it's coming out of the eye, pushing out of the eye. So the answer is not necessarily viscoelastic at this point in time. The question is what's going on, right? It's true we think about all the causes of posterior pressure, external and internal. So external, you spoke about speculum. You think about maybe the patient is very heavy set, Valsalva maneuver. They're squeezing the eye. Those can all be contributing, but in my experience, usually it's not this extreme. It's a little bit, you can stabilize it, but this is extreme. So then there's internal causes, and the big ones you think about are which ones? There's suprachoroidal hemorrhage, right? There's intraoperative malignant glaucoma. Some people call it aqueous misdirection. And there's fluid misdirection, where the fluid is infusion is going behind. Of these three issues, usually fluid misdirection is slow. Slowly the chamber becomes shallow, not acute. In acute situation, the chamber probably shallowed between the instrument removal, and all of a sudden we lost pressure and something happened. So for me, the big point is this a choroidal hemorrhage? Because if it's choroidal hemorrhage, vitrectomy can make it worse. If it's not choroidal hemorrhage, then a vitrectomy could be very good, right? So in this case, we did examine the patient. The fundus was flat, no problem. So in this case, doing a pars plana tap, this is an old video, you can see 20 gauge MVR blade. Look at that liquefied vitreous come out. Limited vitrectomy, we go on to position 3 for perhaps not more than 5 seconds, just enough to get the vitreous decompressed. And it's important when we do this to reform the anterior chamber, to deepen the anterior chamber soon. Of course, we have to reposition the iris. It's not easy to do this. We do it by a sweep method, as well as directly pushing the iris back. Now you can see it's much easier. The eye is soft, and the incision is sutured, and we have solved the problem, although there is some iris trauma. So this is a case of malignant glaucoma, where basically the patient, all of a sudden the choroid expanded, and the vitreous was pushed forward. And that was the important thing. Now, the other case we're going to show is a case, or do you want to make a comment? Microphone?
JJ, the microphone.
You have to do something else there because you have a malignant glaucoma during the surgery, and you can have a malignant glaucoma after the surgery.
You can have it after the surgery, and so you can do a unicameral eye.
Yeah.
I usually find, interestingly enough, when we solve the problem on the table, the patient is stable afterwards. But it wouldn't be wrong to do a one unicameral eye, to do an iridozonular hyaluvitrectomy, to put the cutter through. But this is an emergency situation to get you out of the problem. And if you want to do a unicameral eye, you could do it afterwards as well. Okay, this next case is a patient who, this should be a routine case. Normal eye, the fellow is doing the surgery. You can see it's left-handed surgeon. It's not one. It's a long surgery, but unfortunately the surgeon developed a PC rent, and the lens material is falling posteriorly. So what do you do here? Well, of course, there's many ways to manage this. We try to bring the nucleus up into the anterior chamber, phaco it there, and there's still some lens material in the anterior vitreous. So not unreasonable to do a pars plana trocar here to try to access the anterior vitreous using a vitrector to remove some of the lens material, as you can see here, and phacoing the rest. And it seems like we are able to get out of the problem for the most part. You can see a combination of vitrectomy and phaco to try to salvage the case. Now, in this case now, we're doing the cortical removal. And you'll see we have now set up a 3-port vitrectomy because we need to do some vitrectomy to remove some lens material. And the cortex is being removed. And as the cortex is removed, you will see something happening on the right side of the screen. So what is this now? This is a suprachoroidal effusion developing into a hemorrhage. Now, the question is, what do you do now? That the anterior chamber is getting very shallow, viscoelastic is coming, the cord is getting bigger, even though we have a 3-port setup for vitrectomy now. What should we do next? I know this is not, this is more VR here, but what should we do now at this point?
I will not talk here because I already know this case.
Yes, okay. Ashraf?
During residency, since very long time, if you have a suprachoroidal hemorrhage during surgery, maintain pressure. They told us, even if you didn't have any instrument, put your thumb closing any wound, even a small, just a pressure to make this blood does not increase. This is the main issue. So just a pressure. It is a phaco, so closing the wound as much as you can. This is the most important, and then think what you are going to do.
Juan, you want to say something?
I had a couple of these back in Chile. And as you say, the first thing you have to do is close the eye and pressurize the eye. Because if you let the thing keep growing,
sure,
depending on the age of the patients and the atherosclerosis, you are going to start to breaking the arteries, and you are going to have an explosive hemorrhage. That is
now,
the next phase.
I should have mentioned, this patient has glaucoma, so the plan was to do a phaco-trab in this case.
Wow.
The pre-op pressure was running at 40 on maximum medication as well. So you close the eye. Okay, so good ideas. You put a suture here, and you close the incision. The pressure is very high in the eye. Fortunately, it's not expulsive. Do we stop here? No? Yes?
I will examine also the retina again with the indirect ophthalmoscope to see what is the sector. If it's a very small sector and it's localized, I will wait for 10 to 15 minutes for the blood clot to clot. I am not a vitreous surgeon, but I think if it stops bleeding, it does not increase, he's going to, this sector, he's going to evacuate the blood. If it's localized.
Gustavo, what do you think? Are you going to refer to retina now, or are you going to continue?
Yeah, my friend. No, I'll leave it like that. For example, I'll close it and just leave it like that.
I think closing the eye would be not a wrong answer. My concern is this patient has glaucoma, they have advanced disease. I know post-operatively this is going to be a problem because this hemorrhage is pretty big. It's so big, I can see it. I can see the ciliary body. I mean, it's a big hemorrhage. But I also have an infusion in the vitreous cavity. So on the table, I very much like to address the hemorrhage on the table because I have an opportunity to drain the blood and also to keep the blood draining afterwards. So we're going to do a scleral cut down. I don't know how many of you do this, but it's not a very difficult procedure. It's a difficult situation. But basically, 4 to 5 millimeters from the limbus, we'll make a linear incision to get cut down to the choroid. I usually make a triangle, and we cut down. Now, I hope everybody has some eye protection here, because you'll see the amount of blood here that will come. And that's the fire hydrant. Lyle wants to show that video, because this is how much blood is there. And you can imagine that we're able to drain all that blood out of the eye. Well, it's important we pressurize the eye at this point because we want to make sure we have pressure to push the blood and to reduce the choroidal. But that's what you can do on the table. I know that it's an aggressive maneuver, but the worst case scenario is that the blood is clotted and you stop and you're done. The best case scenario is you actually have drainage. You will not eliminate the choroidal, but you can reduce the choroidal, pressurize the eye, normalize the pressure a little bit. And of course, I do not recommend going and putting a lens in now. I think this is wise to leave the patient aphakic at this point in time. Now, the other problem is the patient has retained lens material. They have lens drop. What do we do about that? Because this is going to cause inflammation, going to cause pressure. What should we do? There's lens material in the vitreous. Lens drop in the vitreous.
Wait.
Wait, okay, wait. Well, I'm impatient, so we're going to go into remove the, Gustavo, this is for you, okay? We have lens material. Look at the lens material there, right? Okay, so there's blood everywhere, but it's controlled. We have an ostomy there. So, of course, it's not wrong to leave the eye here. Not wrong to leave the eye. But we want the lens material. We're going to remove the lens material quickly, as easily as we can. It's important to maintain pressurization. Now, the benefit here is we have posterior infusion. The infusion really helps to keep the globe formed, limit the extent of the choroidal, and actually you'll see at the end of the case, we close the eye, keep the sclerotomy open. So this opening we leave open. We do not close it to allow for the liquefied blood after 1 week to drain. And 2 weeks later, you can see there's a small choroidal present. But after 2 weeks, the retina is flat, the pressure was normalized, the lens material is out of the eye, and we come back about 1 month later to place an IOL and also to place a microshunt in this case, or the Preserflow in this case. So that was the positive pressure case. It's an extreme example. It's risky, but I was hopefully, maybe I was lucky. We'll say I'm lucky, right? Maybe God helped, I think.
One comment, if it's happened, I should look for the blood pressure.
Yes.
Sometimes, if it's old, if this is an old patient, sometimes it can shoot blood pressure without control, especially during local anesthesia is different than general anesthesia. General anesthesia, the anesthesiologist can control the blood pressure the whole surgery. But during local, it's very difficult to control the blood pressure.
Just to watch it again. No, you're right. Absolutely. And when we come back to the operating room, we make sure the blood pressure is under control, monitored, sedated, because this is one of the risk factors.
Yes.
Absolutely.
Yes.
Absolutely. Okay, that's the most blood you'll ever see in ophthalmology in an eye case, right? We have to cross and type for a blood transfusion.
Yeah, we have to talk about the transfusion, yeah.
Okay, so that was sharing with you a situation of dealing with positive pressure in 2 cases. Well, listen, I mean, I'm going to continue on. I'm going to make this short because it's the end of the day. But, you know, this topic is an important topic to me because we are very proactive now in doing surgery for glaucoma, which is a change in the way we treat glaucoma. But we must think about, again, the importance of thinking about the decision-making in these cases. So the question is when to operate. I'm going to say, like, listen, I mean, it's an immense privilege to do what we do. It's a sacred trust between us and our patients. It's a large burden on our shoulders to deal with this, and we have a unique satisfaction if we can treat the problem with our hands. The factors in making a decision to operate are multifactorial. The age, the risk versus the benefit versus the effort, and the opportunity. These are all important factors when we think about it. Opportunity means we have a chance to do something because we're already going to be in the eye, or opportunity to change the course of the disease. Really, we're talking about the risk of glaucoma and topical therapy versus risk of surgery. In glaucoma, that is the balancing act. In cataract surgery, it's very different. The risk of cataract removal versus you have your vision that is reduced. So we have to balance out. And when the risk of surgery is more than the risk of no surgery, we must not do surgery. On the other hand, if the risk of surgery is less than the risk of no surgery, then we should think about doing surgery. But there's multiple factors. How do we decide the risk of no surgery? Visual fields. What's the risk of the patient's going to get worse on visual fields? Contrast loss. We talked about this earlier. Ocular surface problems. Systemic adverse events. And compliance are all factors. But we have to balance this out between serious surgical adverse events. And this is the balancing act. But there's another problem. The risks are not all the same in terms of timing. We have to think about what is the time horizon to the risk. Some of these risks will take many years to manifest. Well, some of the risks can happen on the same day of surgery, like we showed you in the video. So it's a complex decision where we have to think about what's the risk of the surgery at the time of surgery and after, and what's the risk of no surgery of the disease progressing. So we have to think about this in terms of risk. What is the risk probability? There are serious risks in glaucoma, snuffing out the optic nerve, endophthalmitis if we do a bleb. We show suprachoroidal hemorrhage. These are all very bad risks. Now, I'm not talking about the less serious risks, like hyphema or delayed visual recovery. Those are risks and complications, but they're not devastating risks like these that would keep us up at night. But there's also a risk of not doing surgery. I'll give you an example. This is a 60-year-old, 28 pressure, 4 medications. Most of us would argue we would not leave this patient. This patient's not going blind tomorrow, but they're high risk of going blind, even though the risks of surgery are there. This patient is progressing very rapidly. 18 on 4 medications, but they're rapidly progressing. We know if we don't do surgery where they're going to go, unless this patient's life expectancy is only 3-4 months, or maybe less than a year, we would do surgery, even though there are risks. But what about this patient? Pressure's 20 on 2 medications, they have previous SLT, the visual field is mild. Is this patient risky enough to leave? Or is the surgery worthwhile to do because the risk is less? And how do we measure that risk of this disease? Well, I mean, glaucoma still progresses, and we still have a long-term risk of glaucoma in the world today. Even though the risk of blindness is reduced, the risk of blindness is still unacceptably high, even in the developing world. And studies that have been done, even in Europe, show that almost 40% of patients will be blind in one eye by the time they die with glaucoma. So although we may not have blindness today with our patient, by the time they die, over many years, there's a high risk they may go blind. So glaucoma is still progressive and is still risky, leaving the patient uncontrolled. And the reality is most patients progress. Most patients progress over time, but they progress typically slowly. And the challenge for us is, can we assess progression adequately, and can we identify the patients that are at greatest risk? Well, there are known risk factors for progression that we may be more aggressive with. These are situations where we may decide, you know what, I'm going to go to surgery earlier. Maybe they have more advanced disease, they have higher pressure, disc hemorrhages, pseudosfoliation, other potentially modifiable risk factors as well. But we often talk about blindness, but what we forget to think about is that even with early glaucoma, patients still suffer. Now, this does not mean they're going blind. It just means that they have problems with driving, with reading, with glare, sensitivity, loss of vision, social isolation. These are even with mild glaucoma. These studies show an example of difficulty with vision and physical functioning. You can see the more severe disease, the higher the risk of this. But even in mild to moderate disease, there's an increasing risk. So our patient may be progressing, not to blindness, but going from mild to moderate disease, but it's affecting their quality of life. This cannot be measured necessarily easily by a visual field. But we also know that as visual field gets worse, even in early disease, patients stop driving, they cannot read as well, they fall more frequently, they are less physically active, and they stay home a lot. And so my point in this one is to say that when we talk about risk of the disease and not doing surgery, it's not just about blindness, it's also about quality of life, as we've shown here. And we talked earlier about contrast sensitivity. Even in mild glaucoma, patients suffer from contrast sensitivity. Nowadays, you do cataract surgery for a patient who's 20, 30, who has contrast loss. We don't think about it. But yet our patients are progressing, even with early disease, and suffering from contrast loss. It's something to think about. And we see a correlation between OCT loss and contrast loss. So even before visual field is lost, when we see nerve fiber layer thinning, our patients are getting worsening contrast. And as we see the RNFL gets worse, we see more vision quality issues. My point is that to wait for visual field to become very advanced, our patients have already suffered in their quality of life. They may not be able to describe it to you, but our studies are consistent to show that. So this is a concern we think about when we balance when to operate. The decision to operate is not easy, of course, but we must consider this as we think about the options for our patients. When do we intervene? Well, when we look at a survey of glaucoma specialists, we see that for most people, the benefit of surgery is more effective reduction of pressure and 24-hour control. What's the advantage of intervening early? Well, we can address compliance. We have better prevention. These are some of the advantages of operating early. What's the disadvantage, however? The disadvantage of operating early, like mixed surgery, is complications. And that's, of course, a reason why we are concerned. And that's why for many of us, we still wait. We still wait for visual field progression before we operate. I do hope that the day will come in the future where we may perhaps think about operating before we wait for visual field loss, before we wait for more advanced progression. And this is, of course, what the effort is now in today's options in glaucoma, which now give us a variety of new options in glaucoma that perhaps are improving safety and may not be as effective, but allow us to do surgery earlier. And this is the goal of interventional glaucoma. And we've talked a lot about the different options that exist today when we think about the options within trabecular meshwork, subconjunctival outflow, and suprachoroidal outflow as well. So I just want to leave you with that, to think about this, to think about the different options. The end of the day, really, we're seeing a change in how we think as surgeons, being more proactive, thinking about catching patients earlier, monitoring them more effectively, and treating earlier. But there's a problem here, because if the medications fail, it's different if surgery fails. Because if medication fails, it's the patient that's failing. Their glaucoma is getting worse. But if the surgery fails, it's your fault. No, really, the patient will look at, you failed. You didn't control the pressure. And that is a big reason why many surgeons don't operate or they delay surgery, because we're human beings. We don't want to be the one causing the problem or failing. But I think we need to rethink this a little bit and set the realistic expectations for our patients and show our patients what can happen between surgery and no surgery. The risk of progression, the risk of contrast loss, the risk of having social issues, physical issues, vision issues, and the success rate of glaucoma surgery, and balance the risk and benefit, while obviously telling patients that still there's a failure rate that may exist. That can maybe help us to balance out these risks and benefits, and hopefully help us to choose wisely when to operate on the right patient with the right procedure at the right time by the right surgeon. And I hope that's how we close this meeting on interventional glaucoma with all the new technologies we have in front of us. We have a long way to go, but we've come a long way. And congratulations again to the entire team. Claudia, thank you much for putting us all together. Lyle, you've been great as well. Of course, we have our hero, Louis Escaf, the general, the master, who brings us together in no other way. So gracias again for having us here. Thank you.
Bueno, muchísimas gracias, Ike, por compartir tu experticia acá en Colombia. La verdad es que quiero agradecerle a todos los profesores que nos han acompañado y que han venido de diferentes países: Canadá, Brasil, Chile, Estados Unidos, España, Argentina y Egipto, que creo que pocas veces hemos tenido primera vez que tenemos a alguien de Egipto acá, a nuestro faraón Ashraf. Chile ya dije, JJ. Y de verdad un agradecimiento súper especial a toda la familia Kofka, a Vanessa por organizar toda la logística, Vanessa Escaf y Vanessa Ishikane en el tema logístico, Claudia, José y mi persona organizando el programa académico, y a todos los profesores también de acá de Colombia, y obviamente a ustedes, todo este público tan lindo. Y pues, hombre, el cerebro de todo esto y el que da el permiso y el que dice sí se puede hacer, pues que eres tú, Luchito. De verdad que nos vamos muy contentos de ver y evaluar, y además poner toda esta cantidad de conocimientos nuevos, y sobre todo el tema del Interventional Glaucoma, que es no esperar para operar a nuestros pacientes, dejar en un segundo plano el tratamiento tópico, pero también saber a quién no debo operar. Entonces, muchísimas gracias a todos por la asistencia, y le doy a nuestro jefe Pluma Blanca.
Bueno, gracias, Lai. De verdad que este curso se armó en 4 meses. Claudia en Inglaterra, Lai en todas partes, porque yo últimamente no sé dónde vive, ¿no? Y el departamento de glaucoma con todos los integrantes, en la cabeza de José Luis. Yo solamente les puse el piso y ellos pusieron el techo. Gracias a todos los conferencistas, la industria que nos apoyó espectacularmente, porque en esta fecha se hacían muchos congresos y la industria estaba un poquito deprimida, ¿no? Pero de todas maneras el apoyo fue espectacular. Me criticaron mucho en mi casa que yo estaba loco de hacer un curso de esto en 3 meses, pero bueno, gracias a ustedes por haber asistido. Y el doctor Arsha tiene una noticia que darnos, y nos está metiendo en más problemas porque ahora quiere hacer cursos de córnea y de glaucoma, y en fin. Arsha, llámatelo. Lo voy a comprometer aquí a José y a ti, Lai, que el doctor quiere a finales del año entrante, 2026, armar un masterclass de glaucoma, y ha comprometido aquí a Lai y al doctor José con su departamento de glaucoma. Como les digo nuevamente, yo les pongo el piso y ustedes ponen el techo, y yo soy aquí un espectador.
Doc, aprovechar el espacio para agradecer no solamente al departamento de glaucoma, obviamente, que ha trabajado arduamente en esto, sino toda la clínica, ¿no? Todo el personal de la clínica que se ha dedicado, cirugía, instrumentadores, todo el grupo. Es un esfuerzo grande, pero es un esfuerzo que se retribuye, ¿no? Es un esfuerzo que vemos para ustedes, pero para nosotros también, en lo que podemos brindar a nuestros pacientes. Entonces, gracias y bueno, magnífico. Entonces tendremos al doctor Armia, Life Surgery, doctor.
This is great. It will going to happen in Colombia. I think Lil will lead it with the SCAF. I think it will be a great add for glaucoma in Latin America.
Gracias.
Además, nosotros somos una institución que, además de prestar servicios asistenciales con excelencia, tenemos programas de residentes, de fellow, y esta es una forma de que ellos puedan también tener acceso a toda esta información que, por lo menos cuando yo hice residencia, y muchos de los que estamos aquí, no tuvimos esta oportunidad de tener profesores de una alta calidad en cuanto a sus conocimientos y también en su condición humana, porque hay, por ejemplo, casi que es de la casa. Ha venido a todos los Facocaribes y el próximo año lo tendremos igualmente aquí, y se ha convertido esto en una familia, ¿no? Agradecerle a Andrés Fernández Vega, que estuvo con nosotros hace 8 años y hoy regresó nuevamente a esta su casa. Entonces, muchas gracias a todos y nos vemos en Facocaribe 2026.
Los invito a todos a FacoCaribe 2026, que este caso va a ser de inspiración para todos.
No te puedes perder el mejor congreso de Latinoamérica, FacoCaribe en 2026.
JJ.